You place the chest tube, and then you're just kind of staring at the drainage system like, what the hell do I do now? Don't worry, here's the part that nobody teaches you. So the pleural space is a potential space with negative pressure. Air, blood, or fluid disrupts this, and the lung collapses and gas exchange worsens. So chest tubes are placed to remove the collection and restore negative pressure and allow re-expansion. There's 3 things that you've got to check. So first off, drainage. How much, what color, and how fast. If you're placing a chest tube in trauma and you get greater than 1.5 liters on insertion or greater than 200 milliliters an hour for 4 to 6 hours of fresh blood, call surgery. They're going to the OR. Number 2 is the water seal chamber. If there's bubbling, this means that there could be an air leak. If there's titling, this is normal with breathing. If there's no titling, there could be an obstruction or the lung fully re-expanded. Number 3, look at your connections and your tube position. So make sure all the connections are taped and the tube is secured to the patient's body and the drainage is below the chest level and upright. What does an air leak mean? An air leak is bubbling in the water seal chamber, meaning the air is escaping from the pleural space into the chest tube system. It tells you that there's a communication between the lung or the airway and the pleural space. There's many causes of air leaks. One of them is expected or normal, and this usually happens early on. So right after replacing a chest tube for a pneumothorax, you can have an air leak as trapped air is leaving. If you have a persistent leak or pathologic causes, think about ongoing alveolar pleural fistulas, like an injured lung parenchyma leaking air, or a bronchopleural fistula. So this would be a bronchus communicating with the pleural space. Maybe the tube is malpositioned, especially if it's in the lung tissue. And then also think about a mechanical problem with the drainage system. So loose connections.